we're very excited that we've sort of been ticking over every month running once of these webinars. And I think we're all getting a bit webinared out in terms of attending evening things. But what we have found that these actually become also excellent resources. So what's amazing about Zoom is that they get recorded. And so I'm punting here the Rudasa YouTube channel, as well as if you are a Rudasa member. If you're not a Rudasa member, please join up. It's for free. If you go to our learning portal, there's a lot of resources available. And so that makes it possible for us to always have up-to-date information available at our fingertips. So we're very pleased this evening to welcome Dr. Geraty. We've got always quite a big, shall I call it, Eastern Cape contingency in Rudasa, and so we have lots of amazing speakers from here. Let me just share this slide. There we go. And yeah, Sian has actually been overhauling emergency medicine here in the Eastern Cape. She's a specialist emergency physician, and she did her internship at Ngwelezana Hospital in KwaZulu Natal. And then after, she did a community service in a year of MO time with Kimberley Hospital, as well as the Eastern Cape EMS, with a lot of travel to rural areas and rural hospitals. And during her emergency medicine registrar training, she spent 3 months working in Tanzania, and after her specialist qualification, worked for 6 months with MSF in Baghdad in Iraq. So she has been in Gqeberha in her dream job for the past 3 years and loves emergency medicine, working with patients and their families during tough times, academics, and seeing clinicians learn and grow, as well as quality improvement projects. Dr. Geraty is passionate about social justice and making excellent emergency care accessible to everyone. And she actually heads the emergency medicine for Walter Sisulu University. So although based in Gqeberha, is also overseeing what's happening here in East London and Mthatha. And we're very pleased to have her here this evening, where she's going to update us and just make sure we keep rabies prevention and post-exposure prophylaxis at our fingertips. Just to bring a small little story to introduce it, we actually had a scenario a couple of years ago now with a child that came into our accident and emergency department. There was no history of bites or any injury. The child was very confused and very unwell. And then our registrar was about to give it, I think, some medication for pain, and the child had a massive hydrophobia reaction to being given the water to drink. And luckily he was on it. And of course, unfortunately, we couldn't help that child, but he was actually able to make sure that all the staff that evening was protected, and we were able to look further at what actually happens within the community. So these things it's one of those things where we have to actually have a high level of awareness to be able to make sure that we are prepared to help both our patients and those around them. So I'm going to hand over to Dr. Geraty. Let me just stop sharing, and then you can share your screen.
Great. Before I do that, I just want to quickly just take a moment just to see who's in the room, if I may, Madeleine. I don't know if that's okay. Just so I have an idea of who I'm chatting to as well. Just as we get started, my talk is not as long as my last one. I realize that bio is slightly out of date. I've now been here for 6.5 years. So in the Eastern Cape, so it's been a while. I should have actually checked that. So working here at Livingston Hospital in the emergency department here. And I just wanted to hear a little bit about those who are attending. Maybe we can ask maybe 3 or 4 of you just to, if at all possible, to put your screens on. I know it's very, very challenging if you are working in rural areas as well. And then maybe I'll call out a few names and see if you can quickly unmute to tell us your name, where you're working, and what drew you to tonight. Why did you decide to attend the rabies talk when we are so webinared out, as Madeleine did say? So if you're able to, maybe pop your screen on if you are able to, and I'll try and otherwise just call out a few names and see if there's someone that can talk. Sambon, I see you've taken your mic, you've put your mic on. Where are you based? Okay, maybe not Sambona. Maybe next on my list, I've got a Felix.
We could also ask people to put in the chat as
able to take their mics.
Yeah, awesome. But also in the chat, maybe give us your names and where you are working.
Yeah, just keen to get a bit of an idea of who's around.
Let's see a little bit what the
Just checking that I'm not talking to blank screens as well. Is there anyone that's able to put their camera on, or just show me that you're there?
Those people are not in the bath and are not busy cooking and are not busy having their tea and not busy breastfeeding. And great, we've got
I once did accidentally put my camera on when I was in the shower. That's a story for another time.
From NMU. Which department are you
Hi,
at?
Kashana, how are you doing?
Hi, I'm in family medicine.
Ah, you
Good,
are new. We
welcome.
were just discussing you.
Oh, I missed that.
Are you the new HOD of family medicine?
Yes, so this
Yep.
is my 4th week there. Yeah, and lots of work to do. How are you doing?
I'm Dr. Madeleine Muller here. I was just bragging to Sean that we finally have her, so I'm very, very pleased to meet you. We will be working together. I'm here at CMH in Tanzania.
And tomorrow we are interviewing for 3 more family physicians. So we are growing.
Very nice.
Wonderful news.
Family
That's
medicine,
wonderful news.
emergency medicine are very closely linked. So we're sort of part
Yes.
of the same family.
Great. Anyone else that's here? Chris, Collins, anyone that's keen to make a note in the chat or give us a wave to let us know that you're there. It's quite it's a fairly interactive talk. It's not as interactive, but it'll be nice to have some hopping in. Katja?
Hi. Hi. So I'm Katja. I'm post-com serve. I'm currently in Cape Town, but I did my internship at Frere Hospital and my com serve in Joburg. So that's when I joined Redasa, and I've been trying to attend the talks because my heart is in rural, but it's difficult finding post-com serve. But that's where kind of my passion is. So yeah, that's why I decided to join.
Great, welcome. Good to have you from Cape Town.
Nice to see you, Katja. It's the influence.
Maybe just, oh, sorry. Awesome, welcome. Well, welcome, and we glad you're from the Eastern Cape at heart. Anyone else? One last person, just to let us know who you are and where you're working. Great. Well, what we're going to do is, I'm assuming I'm being recorded, Madeleine. Let me share my screen so long, and let's jump into it, because obviously this is something we can hopefully share at a later stage as well. So if people are busy and running around and trying to get things done, then at least you've got access to here and access to the resources as well. So you should be seeing my screen. And the title of my talk is Rabies. It's 100% fatal and 100% preventable. Now, we know that nothing in medicine is 100%. We know that patients do not read the textbook, as we're going to learn a little bit about today. But I'm going to start off with a case that is potentially fairly similar to the one that Madeleine shared. This is an actual case that did come into our emergency department a few years ago. Was a young man, probably in his 30s. He came in acutely agitated, very, very, very aggressive, confused, a little bit all over the place. He was potentially a bit feverish as well. And we were in the process of examining him and going through the process of trying to figure out what was wrong with him when somebody noticed that he had a horrible festering, what looked like potentially a dog bite on his leg. And his family then did confirm it looked like he'd potentially been bitten by a dog many weeks before, but for various reasons had not actually sought any kind of medical attention. Right. Does anyone have any ideas what might be going through your mind? What might be some of the causes of this condition? What might be going on? Right. So the talk is on rabies. So obviously rabies was not the first thing on our list, but somebody did come up and say, well, this person's been bitten by a dog. Could this potentially be rabies? Obviously, and really importantly, and I'm sure many of you would have thought about this as well, things like meningitis was on our list as well. Substances, mental health care conditions, delirium. There were many other things that were actually potentially going through our heads at this point in time as well. And so we started to think, could this person potentially meet the case definition for rabies? And what is the case definition for rabies? Now, it's rare, but not that rare, as I'll tell you in just a moment. But obviously, finding any kind of images are very, very difficult. This is a patient who was diagnosed with rabies, and this image was taken from this website, and it shows someone with very, very much agitated delirium. Now, we all know whether you're working in urban, rural, public, private, a delirium is a delirium. Patients can be confused, they can be agitated, they can need restraint, they can need sedation. Yes, absolutely. If we're thinking rabies, you might be thinking something like the hydrophobia, so sort of, almost a choking and an inability to take anything in orally. But to be perfectly honest, many patients with strokes can look like that as well if they've got swallowing difficulties or bulbar palsies. And so rabies may be one of many, many, many other differentials, I think, is the main sort of point there. And so the question is, what is, and this was sort of going through our heads, what is the definition? What is the case definition for a suspected human rabies case? And this is from the NICD. A case definition is a patient presenting with an acute neurological syndrome. So that's exactly it. Rabies affects the nerves. It is a lyssavirus. It is transmitted via saliva, via the neurons into the central nervous system and causes severe damage then. One of the ways, at least I think one of the ways that rabies has evolved is essentially to create its host to be extremely aggressive, snapping, biting, and then continues its way of actually being spread that way. In other words, it's then spread from the saliva to the next organism. In humans, majority of the time it is a zoonosis. In fact, pretty much 100% of the time it is a zoonosis. There's no known human-to-human spread so far. It's mainly been a zoonosis. So in other words, animal bites, predominantly canine bites, and we'll talk a little bit more about the animals in just a second. But basically, essentially, there has been some kind of a syndrome, there's been some kind of an exposure, and this person presents with this acute neurological syndrome. The classic rabies, in this case, we talk about the hyperactivity that I was speaking about, that agitation, that fighting. I learned today that it actually comes from the Roman word rabere, which actually means to rage or to rave. So 80% of the time, if rabies is going to present, it's normally going to be this kind of hyperactive, agitated type of delirium. However, 20% of the time, it can also be sort of a paralytic sort of a syndrome. So patients come in looking catatonic, they come in looking comatose, they come in with kind of a weird neurology. I mean, that used to be kind of your classic dumb rabies, as it's rather archaically termed. And it's extremely aggressive. It progresses to coma and death, usually by respiratory failure, within 7 to 10 days after the first symptom. So 100% fatal, pretty much. Basically an incredibly debilitating and then ultimately fatal disease in humans. A probable rabies case is when you've got the case definition and there's quite a clear-cut exposure. So quite clear-cut, I was bitten by a dog, the dog died a few days later, the dog was, hypersalivating and looked sick and looked unwell and had strange behavior, which is why they bit me. But just to be aware that the exposure, although it usually takes about 3 weeks to 3 months to present, it could be anywhere from 2 weeks to 2 years, even more years. It could be years later that it actually finally presents. So how do we go about managing these cases? Everything that I'm going to be telling you today, I'm very grateful to the NICD, and in particular, Prof. Bloomberg has been instrumental in giving us a lot of information about rabies. She's some of the photos and pictures I'm sharing are directly from her. She shares, we share a passion for seeing rabies prevented in South Africa, and for making sure that healthcare workers are well equipped to be able to manage and prevent rabies. And the National Institute for Communicable Diseases gives you a lot of this information. Pretty much, if you want to stop listening now and you just want to go and log on the website, you'll pretty much find all of the information there. But I'm hoping that I can take it and make it digestible and fun to listen to as well. All right, so how do we manage these patients? I didn't share this just because the NICD is a fantastic resource for everything that you're looking for, but because the way that I actually remember how we manage human rabies cases is actually using the acronym NICD. All right, it's not ABC, I am an emergency physician, but in this case, I'm using the acronym NICD, notify, investigate, consider differentials, and then the S is for supportive treatment. So we're going to go a little bit more into it. So notify. Does anyone want to guess or let me know what category notification you think it may be? I would say there's only 2, but apparently there's now 4. But the, category C and D are apparently notified from the lab directly. So as clinicians, there's 2 types or 2 categories of notifications. There is category A that needs to be notified within 24 hours, and category B that needs to be notified within 7 days. Any guesses which on rabies would be? You can pop it in the chat as well if you want. I'm sure Madeleine will keep an eye there. Yeah, so if you've said A, you're obviously correct. It is not if you have a case of suspected human rabies, you certainly don't want to be sitting on it, keeping them in your hospital, wondering, what might be going on when potentially the dog is still walking around. Potentially there have been other exposures that may have happened. So this is something we want to be letting the NICD and as via the NMC, you want to be letting them know as quickly as possible. As a side note, notification is not only when you have a suspected human rabies case, it is also when you have any kind of a dog bite, any kind of an exposure. They do need to be notified whether or not you are continuing with the post-exposure prophylaxis. We do need to be notifying, and in fact, in our unit, every single dog bite that comes in is actually notified to our infectious disease coordinator, who then notifies that to the district as well. Your NMC reporting, I'm sure many of you have gone through this and done this, so you don't need me to take you through it, but you can do it on the website. You can do it on the NMC reporting app. You can also, if you do need to, I love that you can call a hotline. All right, so there is an NMC hotline if you're not too sure. I might have rabies. How do I test? Or I might have a patient with rabies. How do I test for it? I'm not too sure whether or not to get post-exposure prophylaxis. There is an NMC hotline, and if you are watching this either on YouTube or at home, I'd actually screenshot this, though obviously everything is available on their website as well. I always love sharing this national poison hotline. I've used it myself. They are also a fantastic resource for all poisonings, but if you do have a potential zoonosis that you do need to contact, they would be able to assist you and put you in contact with the right people as well. Next step, how on earth would we try and investigate these? So we know that rabies is spread via saliva and via the nervous system. So really saliva, sometimes skin, and CSF can be sent for an RT-PCR to the NICD lab. As we know, many diagnoses of rabies are made post-mortem, and so brain, skin would be the diagnosis of choice. For animals who have died and there's a suspected rabies outbreak, brain biopsies are pretty much the best way that they actually do make this diagnosis. Consider differentials. So we spoke earlier about meningitis, encephalitis, head injuries in these patients, neuropsychiatric conditions, porphyria. Don't forget, porphyria could look like anything. And obviously toxins and medications are all differentials that you need to be considering in the patient with an acutely agitated or even comatose mental state. Rabies should probably be a little bit further down on your list if there hasn't been an exposure, but think about these other things. So fortunately, in our case, the gentleman had actually, unfortunately, did have a neuropsychiatric condition. He presented with an agitated delirium secondary to substance-induced psychosis. His dog bite that had been uncared for was largely as a result of his mental state over the last few weeks. And he, although as a septic wound with a bacterial infection, he fortunately did not actually have rabies, which we were very grateful for. And he went on to make a full recovery. And then finally, rabies is universally fatal. These patients, unfortunately, would not qualify to go to ICU, for example, because we know that they are likely going to die. It's a resource that we don't necessarily, we're probably going to give that ICU bed to someone that has something that's actually potentially reversible. So a huge part of what we will then be doing is making sure that we are honest with the family, letting them know what to expect, giving them a chance to see the patient and to say goodbye. And to a large extent, we're going to then be moving very much from a resuscitative strategy in these patients to a palliative care strategy, including pain medication, sedation as needed, managing dyspnea, and making sure that they are as stable and that they can die in a dignified way. So I've said that rabies is 100% fatal. It's not entirely true. Does anyone know how many rabies survivors there have ever been? I'm losing my screen a bit here. Right, so the answer is that they've actually been round about between 30 and 45. Many of them have been in India, many of them in Africa. There's probably more that we don't actually know about. However, the one thing that pretty much all of them have in common is that they had received some form of vaccination or immunoglobulin. The majority of rabies cases worldwide occur in Africa and Asia, as you can see from this picture. The dark red, the highly affected areas, are the areas that are most affected by, and as you can see, mainly canine rabies. And because of how closely dogs and humans live together, the canine rabies or the canine bites are the most common cause of rabies. It's estimated that there's 59,000 deaths per year. I'm going to say that again, 59,000 deaths per year worldwide from rabies. And of those deaths, 95% of them are actually occurring in these big, highly affected areas in your Africa and your Asia, especially India is largely spoken about. As I say, so 59,000 deaths a year, 45 people have survived ever that we know about. And just about all of them received some kind of post-exposure prophylaxis. Most of the time it wasn't adequate. They either did not receive the full vaccine or they did not receive immunoglobulin. There is one odd case. You may have heard of Gianna Gisi. Gianna, this is Gianna now. She was 17 years old when in Wisconsin, I believe it was, she went to rescue a bat that was flying around her church. She managed to catch it. She took it outside and in the process got a few nips to her hand. She thought nothing of it. She sought no medical attention. She received 0 post-exposure prophylaxis. And about 3 or 4 weeks later, she started developing signs and symptoms of rabies and was diagnosed with it. She was treated, so I say it's a bit odd that she's in Wisconsin, she was treated with the Milwaukee protocol, and basically essentially was put into a coma and received antivirals. And despite the fact that this same protocol has not been shown to improve outcomes in anyone else ever since then, which means there's very, very little evidence behind it, she miraculously made a not full recovery, but although she still has some neurological sequelae, she has gone on to have quite a full life. She's married, she has a job, she has kids. So quite a miracle. However, we're not too sure why she survived rabies without having had post-exposure prophylaxis, and no one else worldwide ever seems to have. The suspicion is that she probably did have a very attenuated form of the vaccine. She obviously was in a very, very, very high-resourced area where she could receive very, very, very highly supportive intensive care. And again, I do believe that miracles happen and nothing is ever 100%. However, for the other 59,000 people who die every single year from this disease, from here, our talk is not moving on to how do we treat these patients who are most likely going to die, but how do we prevent rabies? Let's come home. So as you can see, this was a lovely map that shows the massive rabies outbreaks between 2008 and 2018. The red dots are the canine outbreaks. So you can see it's very, very thick. If any of you are practicing in KwaZulu Natal, especially, or if you, like me, you are working in the Eastern Cape, or you're in Mpumalanga or Limpopo, you can see there's lots and lots and lots of red dots all over there. So Kashana, you would have known from KwaZulu Natal. I'm sure you guys did see a lot of, or hear a lot of kind of exposure to canine rabies. In the Eastern Cape in particular, we had a massive outbreak in 2021 in Nelson Mandela Bay, specifically lots and lots and lots of dogs with rabies. And unfortunately, at least that I'm aware of, 2 child cases of rabies. People always told me in the Western Cape there was no rabies. Not entirely true. They are indeed, as you can see, there's a couple of scattered red dots there, but mainly in the Western Cape, the Northern Cape, but unfortunately in the rest of the country as well. Our wildlife rabies is still very endemic as well. Just keeping an eye on the chat there. Yes, seeing that yes from Kashana. Yep. Agree, category A. Thanks for the chat. That's great. And yeah, the sepsis was definitely a differential there. Great. So keeping on with the epidemiology, in South Africa alone this year, we are only in October, so in the first 9 months of the year, there have already been a total of 7 confirmed cases of rabies, as well as 1 probable case of rabies. The NICD dashboard shows this really nicely. If you are looking for any epidemiology, you can go and have a look on there. And you can see, again, Eastern Cape, KwaZulu Natal, sort of taking, really taking the brunt of the cases, with quite a lot of cases in Limpopo as well. Interestingly, again, the Eastern Cape, they don't say exactly what the sources were. There was an unknown source, an other source, and a dog source. But essentially, so interesting where the exposures were coming from. But very sadly, all 7 cases that had rabies in South Africa this year have died. Some received vaccination, but not rabies immunoglobulin. Some patients didn't seek healthcare attention at all, which means that part of our prevention strategy actually needs to be how we educate the community. And then very sadly as well, one actually did seek healthcare attention, was told that they were a category 1, which makes no sense. And we'll talk about the sort of categories and kind of what makes sense there. And didn't receive the vaccination, didn't receive the rabies immunoglobulin, and then went on to die from rabies. And so the massive point of this talk is that it's all very well to know how we might manage and provide palliative and supportive care for rabies. But our job as healthcare practitioners is to raise awareness and to ensure the prevention and the post-exposure prophylaxis so that patients don't go on to contract and die from this terrible, terrible disease. And I see Madeleine is saying, and there were donkeys as well. Children are disproportionately affected by rabies. As you can see from this picture, kids are small, they may not have the wisdom of adults, there are always dogs around, they want to play with them, they want to run up to them, they want to see what's happening. And so children disproportionately, as you can see from this graph, which is a little bit of an old one, but it still holds true today, you can see that in the 0 to 9 category, they have far, far, far more higher cases of rabies than in the rest of the age groups as well. So that's also very sad, and another reason for us to really focus our efforts on how we prevent rabies. I'm very grateful. There was a really lovely talk on the Med Talks as well by Dr. Msimang, who's an epidemiologist from the NICD. And this is just to give you a little bit of an idea of what the sort of rabies cases per animal species are currently in South Africa. Just a fun fact, a friend of mine called me in a panic a few weeks ago. Her daughter had gone to Monkeyland in Cape Town and happened to be bitten by one of the monkeys. And she phoned me and she said, do we need to be worried about rabies? And I said, well, I don't know if she needs to be worried about rabies. So I spoke to Prof. Bloomberg and she said, we don't need to be worried about rabies in monkeys. You know, if they are in a place where they're safe and they have been vaccinated and there haven't been any cases of rabies in monkeys. We always think of it as being a monkey thing. It is really not. Your biggest things are your dogs, right? You can see massive, massive outbreaks in dogs. And then there are in your wildlife animals as well. And then, but be aware, it is in cats, it is in cattle, can be in your sheep, horses, pigs, and I'm assuming donkeys are definitely going to be on that list as well. Interestingly enough, in South Africa, if you've been watching the news, you'll be aware that there has been a huge outbreak in the Cape fur seal population. Now, I know my husband did point out to me this is a leopard seal, not a fur seal, but I like the picture. And we're now at a point where, because of the seal-to-seal spread, it's actually being termed as endemic in the Cape fur seal population in South Africa. It's the first ever rabies outbreak or rabies to be endemic in any marine population. And again, we are a little bit concerned because seals and humans do interact in very much the same waters. In fact, I took my dogs for a walk on Sardinia Bay Beach, and it was about a year ago. and came across a seal. He was just sort of chilling there, looked a little bit angry, showed his teeth at some children walking past. I thought, yo, this just seems like a rabies accident waiting to happen, you know, dogs running off leashes and things like that. So your dogs can be exposed to seals, but so can humans, surfers, swimmers, etc. So how do we prevent it? Firstly, incredible work being done by people like the South African Veterinary Council, South African Veterinary Association, the state vets of South Africa as well, looking at massive vaccination campaigns. Here you see cows being vaccinated. Part of the reason why the Nelson Mandela outbreak was contained in 2021 was because of the mass vaccination campaign of dogs that did happen in our area. And I can't remember the exact stats, but what Dr. Msimang said was that it had basically gone from sort of hundreds to really, really under control, even in Nelson Mandela Bay and the dog population, which is really wonderful and really due to a lot of work there. If you happen to be working in family medicine or in kind of a GP practice where you may be seeing people who are at high risk for rabies exposure, or if you yourself are planning on going through a trip through Africa or going to India, and you might be going somewhere where there may not be post-exposure prophylaxis access, you do want to think about getting PrEP. Interestingly enough, Prof. Bloomberg mentioned that if you are going to be in the waters of kind of the Western Cape, sort of up to Plet, a little bit on the West Coast as well, if you're a big surfer, a big open water swimmer, where you might find yourself being exposed to the seal population, you may actually want to think about actually getting your pre-exposure prophylaxis as well. It can be given either intradermally or intramuscularly. It is on 2 days, 7 days apart. And your intradermal is actually a slightly smaller dose than your intramuscular dose. The nice thing is, if you do have someone who is properly post-exposure, who's received post-exposure, who has received pre-exposure prophylaxis, your post-exposure prophylaxis can be a little bit reduced, so they don't necessarily need rabies immunoglobulin. You do want to then go on and continue their vaccination course, so they're going to need boosters on day 0 and day 3. If you are seeing someone in your unit who has had an exposure and they have received pre-exposure prophylaxis, again, have a chat to the NICD, call them on the hotline, and you can decide together with them how much PEP they would need. But then we get to what is really going to probably be the bread and butter for most of us here. If you're working in rural areas, if you're working in emergency departments, when you are seeing that person who comes in and says, I have been exposed to rabies, I've been bitten by a dog, I've been bitten by a cat, I've been bitten by cattle or by a bat, and then actually how we actually prevent this from happening. All right, so the 3 mainstays of this is wound care, doing a bit of a risk assessment. All right, we'll talk through now about how we do a risk assessment, and then considering the vaccination and the rabies immunoglobulin as indicated. One of my big take-home points that I actually want to say today is forget the categories. I think the categories can get a little bit confusing. We've all heard about category 1, category 2, category 3 exposures. And although we'll touch on the categories very briefly, my big take-home is don't think about the categories, because is a category 1 going to present to the emergency department? No one's going to come walking into the emergency department saying, oh, I saw a dog. I was in the same room as a dog today. You know, that's, you would just say, okay, that's nice. No one's going to come into the emergency department saying, you know, I got licked in the face today by a dog. You know, it's not the kind of thing that it's really appropriate for. I think the categories are very appropriate for if you are involved in district health or epidemiology, or you are responding to an outbreak and you need to go out to somewhere where there has been a rabid dog, and then you need to kind of go, okay, who was licked by the dog? Who was in the same room as the dog? Who, you know. But if you are seeing someone who has been bitten or has been scratched or has got a scratch or has got a break in their skin, that person needs post-exposure prophylaxis. If you have a wound that has been caused by an animal that might have rabies, that person needs the full post-exposure prophylaxis, which means washing, a full course of the vaccine, and very importantly, rabies immunoglobulin. This is going to turn into a very boring lecture because I'm going to say the same thing over and over again. You need to do all 3 things in this case. somebody presents with a dog bite, you're going to start thinking about your tetanus prophylaxis. Be aware our tetanus prophylaxis guidelines have changed. I'm not going to go into them, but if it is a massively contaminated wound, maybe the person was bitten or attacked by dogs, or dragged through and it happened in a very sandy area and it's a contaminated wound, you might need to think about not only updating their tetanus vaccination, but you might need to think about tetanus immunoglobulin as well. Those guidelines are available on the NICD website, but they're also on EM guidance. Go and have a look at those. So think about your ATT. Think about antibiotics. I must say, where I practice, where we do have a lot of patients who are immunocompromised, dog and cat mouths are dirty. You may want to think about actually getting antibiotics into them. And very importantly, just in terms of the wound, you do want to avoid local anesthetics and suturing. The reason for that is that both of those two things can actually cause additional spread of the rabies in the wound, which is the exact thing that we want to prevent. Now, a note on washing, right? We want to be washing this wound with soap and water, just normal soap. It doesn't even necessarily, if you don't have your heavy scrub or your fancy soaps, normal soap and water. If you are working in rural areas or you are giving advice to clinics and even more rural areas that are referring up to you, soap and water is exactly what you need. But what I'd like you to all do now is I'd like you just to maybe just have a look at the time. I think it's probably just going to be the easiest. What time is it? I'm going to glance at my phone as well. All right, 18:38. I'd like you to tell me when it's 18:48. Can you do that? All right, somebody get out your watch, set a timer, have a look. Let me know when it's been 10 minutes. All right, 10 minutes is a long time. We need to be washing these wounds with soap and water for at least 10 minutes. That is a huge takeaway. A huge part of actually preventing this rabies from spreading is making sure that those wounds are properly washed for a good 10 minutes. You can then apply alcohol and iodine solutions after that, but 10 minutes, soap, water, and scrubbing out those wounds. Then you want to do a really good risk assessment. And this is a super important part of assessing what kind of post-exposure prophylaxis and what further steps you're going to take with this patient. Is your patient immunized? Again, we've seen how that's going to change our post-exposure prophylaxis. Have they been previously bitten by a dog and received post-exposure prophylaxis, including a full vaccine? Again, that changes a little bit how you're going to see. Are they immunocompromised? If they're immunocompromised and they did receive previous PEP, you may still want to think about giving them the full course again and rabies immunoglobulin, because we know they might not have mounted as good a response again the second time. Think about exposure factors. All right, geography. If they got bitten by a dog in Australia, they are probably fine. All right. If they got bitten by a dog in the Western Cape, you still want to do a nice, you still want to do a really, really, really good risk assessment. What happened? Where was the dog? What were they doing? But if you get bitten by a dog in the Eastern Cape or KwaZulu Natal, you are probably giving the full course and the rabies immunoglobulin regardless. But have a look at your animal health. If it's a well animal, if it's a mom with her puppies, for example, and she's been perfectly fine and she snapped at somebody that was irritating her and then she carried on being completely healthy, probably chances are that the risk of rabies is a lot less than that. Animal behavior is massively, massively, massively important. And we're going to go through some examples of what is weird behavior in animals. Animal vaccination status. I have drilled into my team so strongly that almost every category 3 exposure gets rabies vaccination and rabies immunoglobulin. I had to run in and stop them from giving rabies immunoglobulin the other day to a gentleman who was caught robbing a house, but he was caught by the police dog. Shame. And so he had some bites that we were cleaning for him, but he did not need anything. He didn't need post-exposure prophylaxis. He did not need vaccination. He did not need a rabies immunoglobulin. Why? The police dog is fully vaccinated. The police dog was trained to catch him. That police dog is perfectly healthy, and the police can let us know straight away if that animal starts acting strange. So a police dog bite, if my dog bites me accidentally, as they often do when I'm playing with them, I'm not going to be worried about getting rabies immunoglobulin. So you've got to have a look at the situation. You've got to put it all together. Where are you? What happened? What is the animal's health? What is the vaccination status? And I would almost say that wound category doesn't really play a role. If it's a bite, it's a bite. If it's a break in the skin, it's a break in the skin. So dogs, we spoke earlier a little bit about this sort of hydrophobia, and how the virus sort of spreads by aggression, by biting. So they can become aggressive if they weren't aggressive before, especially a lot of drooling, hypersalivation, snapping at imaginary objects, and the muscle paralysis. I have a good chuckle when I read this because my dogs can be aggressive. They drool a lot. They snap at imaginary objects all the time. I think they're snapping at flies, but they're really not. But they don't wobble. So, you know, so you've got to look at what's normal for that dog and have a look at other things from there. Cats, again, very aggressive, lots of snapping, lots of kind of strange sounds. Cattle, goats, they talk about kind of a bone in the throat. So they almost have a bit of a choking, lots of bellowing, you know, and again, these neurological symptoms. So they're kind of not able to walk, and the hindquarters sort of fail. Again, in your cattle and in your bovine populations, it might be multiple animals that are affected. And then wild animals, always worry about tame animals that become wild and wild animals that become tame. Again, you have your police dog, trained to be aggressive, trained to bite if needed, but fully vaccinated, acting within its trained behavior, acting within normal behavior. We are not stressing about those sort of exposures. This is my extremely aggressive Kingsley, barking for absolutely no reason, snapping at imaginary objects, but he is fully vaccinated. He did accidentally bite me the other day. We were both we were playing. It was definitely not his fault. He's not that aggressive. And he, you know, I don't need any kind of a vaccination or post-exposure prophylaxis there. This is probably one of the most terrifying images I've ever seen. I've taken it from a thesis from the University of Pretoria. And this shows a kudu coming into someone's house and not being afraid of the person who's standing there. So we spoke about the wild animals that become tame. A kudu should not become tame. This kudu had rabies and was acting very, very, very strangely, and wild animals coming into houses. And again, your cattle can bellow and drool, and many can be sick. You see there's a couple there that are lying down and not feeling well. So again, forget the categories, but just to quickly take you through, we used to call this a category 2 exposure. If there is a scratch, if it has broken the skin, treat it as a category 3. All right, these are what we call category 3 exposures. They are bites. You can see there are scratches there. There's bleeding. On this one on the left, it's a teeny tiny little puncture mark. That is a category 3. This patient needs full post-exposure prophylaxis, wound washing, full course of the vaccination, and a full course of the immunoglobulin. Face bites are extremely high risk, as are hands for that matter as well. They are very, very, very lots and lots of nerves. I don't know what the word is, like very neurological, very vascular as well, and they're obviously very close to the brain. So the virus can spread very quickly. And you can see from these pictures, these are all children. Again, more likely to get bitten on their face, far more likely to actually contract rabies. So I've put a bit of an X here, just almost a little bit tongue-in-cheek, but essentially to say that if you have a patient with an animal exposure, if they have got a breach in their skin in any way, or they've got a lick to their mucosal membranes, or they have a lick on an existing scratch, you are treating that patient as a category 3. They're getting their wound management, they're getting their rabies immunoglobulin, and they are getting their full course of the rabies vaccine. Okay, the rabies vaccine, we give it on day 0. So day 0 is your day of presentation. It needs to be given again on day 3, day 7, and day 14. So it's 4 doses that are given. Just very, very careful. It needs to be given in the deltoid muscle in adults, and you need to think about giving it in the anterolateral thigh in children. It is ineffective in given in the gluteus maximus. So no vaccination of rabies is supposed to be given in the gluteus maximus. A bit like a snakebite antivenom, the dose is the same for adults and children. So if you're giving an AMP for adults, you are giving an AMP for children as well. And if you have a look at the new poster and the new guidelines, it is there as well. Why is it ineffective in the gluteus maximus? I have no idea. I don't think we actually know, but we do know, and it has been proven that there have been case studies where post-exposure prophylaxis has been given in the gluteus muscle, and it's been ineffective, and those patients have gone on to develop rabies. So please, 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 all rabies vaccinations to be given deltoid in adults, anterolateral thigh in little ones. And then, probably the most important part, make sure that the patient receives rabies immunoglobulin at the correct dose in and around the wounds only. I don't know if any of you were around when we used to teach, or I certainly used to practice as well, that you used to give half into the wounds and half intramuscularly. That is no longer the practice. We give the rig in the wounds and around the wounds only, right? And we have seen that not only does that save lives and save cost, but it actually doesn't really make much of a difference if you actually give it intramuscularly. It needs to go where the virus is. Your rig needs to be given as soon as possible, but within 7 days. So rig is not something where you're going to go, okay, go home, you know, keep an eye, see if I'm looking out for my 48. Is that the 48 minutes? Is that what's going in the chat? That's the 10 minutes up. Okay, 10 minutes of washing. That was a long time. All right. So we've only just now stopped washing the wound. All right, 10 minutes, soap, water. It's a long time. Good. So your rabies immunoglobulin, you don't want to be sending them home saying, come back in 5 days if you're, you know, if the dog's not, if the dog starts to get sick. Rather give the rabies immunoglobulin. If there is any doubt, give it as soon as possible. So that patient walks into the unit, you're already thinking about how you're going to actually get the rabies immunoglobulin into those wounds, but within 7 days. If the patient presents after 7 days, it is shown it's probably ineffective to give the rabies immunoglobulin. Rabies immunoglobulin as soon as possible. If you have access to the human immunoglobulin, it is 20 units per kilogram to the Rabigam that we use. It is given into the wounds. If you have lots of wounds, I once very, very sadly had to treat a patient who had been attacked by multiple dogs, had multiple bites in multiple places. You need to make sure that all of the wounds receive coverage with the rig. So what that means, if your 20 units per kilogram does not provide enough volume for you to be able to inject a little bit into every single wound, you need to dilute it. So you can take that rig, you actually dilute it up with saline, and you give a little bit into every little wound to make sure that every single wound, every single bite has actually received rabies immunoglobulin. It becomes a bit tricky with small wounds. We had an interesting case where we actually had someone who was exposed to a rabid seal. She was working as a marine biologist on one of the seal expeditions, and for some reason hadn't received her pre-exposure prophylaxis. And she had a tiny, tiny bite just on her nail. And we had to give the rabies immunoglobulin essentially almost under the nail bed. Extremely, extremely painful. We'll chat now about how you can manage pain and how you can make things better in just a second. But essentially the idea was to actually give as much of the immunoglobulin into that wound as possible. Remember, face and hands are extremely high risk. And for children, and I would say maybe even for adults as well, please consider doing procedural sedation and analgesia. It's extremely painful. We've already said that you don't want to be giving your local anesthetic. You don't want to be suturing these wounds. However, with this pain, especially if you want to make sure that you're giving the rig adequately and also not to cause trauma to this child who has now already been bitten by a dog and needs another 4 days of the vaccine, please consider doing procedural sedation and analgesia. Get your ketamine. We are good at it. We do it all the time. Wash those wounds really, really, really nicely, and then give that rabies immunoglobulin, and then just make sure that your nursing staff have also just given that vaccine while the child is still under sedation. And then it's only the next 3 vaccines that they need to then get poked. If there is no rabies immunoglobulin available, this is really important. If you are working at a facility now that doesn't have rabies immunoglobulin available, you need to know what your plan is. You cannot just say we are going to give the vaccination. Someone told me today about a case where they didn't have rabies immunoglobulin, and someone senior suggested they just give the vaccination and send the person home. Absolutely not. Especially if you're working in a rabies endemic area. Please find out what your local protocols are and how to get rabies immunoglobulin. If you have to transfer that patient up to your tertiary hospital to get rabies immunoglobulin, then that's what you need to do. But we need to make sure that we do have rabies immunoglobulin everywhere. You're welcome to contact me. I'm sure Madeleine as well, if you are working in facilities that don't have, and we can try and see how we can support with making sure that we get the rabies immunoglobulin to you. With that said, right, Rabigam is out of stock in South Africa. All right. So yes, you're probably not going to have the human rabies immunoglobulin at the moment. We are, however, then using your EquiRab, which is your equine immunoglobulin. It is available under a Section 21 application. It's a little bit more admin, but it's actually not that difficult. Again, if you need help with the Section 21 application, please get in contact with me, and I can definitely help you with that. Just a couple of things to be aware of. It is 40 units per kilogram, not 20 units per kilogram. So if you're seeing this little vial in your unit, it's not Rabigam, it's EquiRab. It is 40 units per kilogram, not 20 units per kilogram. And it's a slightly higher risk of anaphylaxis. You are not going to be giving a test dose. The Rabigam needs to be given, right? This is life or death. It's not like you're going to give a test dose and then see if there's an allergic reaction and not give it. You do need to give the Rabigam. But if the person does go into anaphylaxis, just go and have a look at our South African guidelines. Basically, it's adrenaline, adrenaline, adrenaline. Know that you can actually manage the anaphylaxis should it happen. I have not yet seen an anaphylactic reaction to either the human or the equine rabies immunoglobulin. What if my patient is pregnant? So pregnancy is not a contraindication to either the vaccine or the rig, right? So do not withhold it in pregnant patients. If they are pregnant, they get treated exactly the same way. What if my patient is allergic to eggs, right? An egg allergy might be a contraindication to Rabipure, which is one of the rabies vaccinations, which is actually not available in South Africa. At this point in time, we have VeraRab as one of our vaccines, but there's actually ChiroRab that's currently available, and you'll see probably where you're working, it's probably a bit more widely available at the moment than VeraRab. Egg allergy, not a contraindication to either of them. Okay. I see the chat box is lighting up. Is it the empty numbers, or is there anything else there that I need to know?
There's a couple of questions, but you can chat about them at the end.
Okay, all right. What I might try and do, just because I'm struggling to keep the Zoom and my PowerPoint on one, what I may ask, maybe again just put it in the chat if you'd like to. I just want to try and get to a point where I can actually see the chat. So let's put it this way. 40-year-old gentleman comes in. He has been bitten by a stray dog. He was walking down the road, saw a stray dog. The dog bit him. His arm looks a little bit like this, and he has now come into your emergency department. High risk, low risk. Right, so if you have said, let's have a look here. Let's see what everyone's saying. High risk, everyone agreeing. Good, all right. So it is high risk. We don't know where this dog has come from. We cannot track the dog. We don't know if this is normal behavior. Maybe it is, maybe it's just guarding his property, but who knows? If you're in an endemic area, it's very high risk. Again, we try to stay away from the categories, but this would be a category 3 bite. It has broken the skin. There is bleeding there. This patient needs wound washing, vaccination, and rabies immunoglobulin. All right, I can never give a rabies talk without bringing my dogs into it somehow. Okay, so this is my dog licking me in the face, which took a bit of time to try and get it to do. High risk, low risk. Okay, so a bit of a lower risk. This would technically be a category 3 exposure. A category 2 exposure. So if you're going back to your categories, but this is my fully vaccinated dog who is just useless. However, if this was a rabid dog and I had been licked in the face, and there was no sort of broken skin there and it wasn't involving mucous membranes, you might then want to consider giving them vaccination and not the immunoglobulin. But to be perfectly honest, I cannot think of a case in my career where I've ever given the vaccination and not the immunoglobulin. Basically, if you have a high risk, you are giving both. And when you are in doubt, rather give both. Okay. How about this one? Someone who was exposed to a cat bite comes in. Cat has been acting a little bit strange lately. He's been a little bit more aggressive than normal, hasn't been known to bite them. Maybe making a few extra sounds that are a little bit strange lately. High risk, low risk. Seeing some high risk, seeing some high risks. I agree. Okay, so yes, this is a category 3 exposure. They may be teeny tiny little bites. Category 3 exposure. The cat is acting strange. Nothing's really making sense about the whole story. You're not too sure what's going on. This would be a case where we would get the wound care, the wound washing, full vaccination course, and rabies immunoglobulin. I think you can see where I am going with this. All right, this patient comes in about 3 days later, had been bitten by a dog, had received a couple of stitches here and there, but essentially had broken the skin. This still counts as a category 3 exposure. And as long as they are presenting within the 7 days, they do need the full course of the vaccination and they do need the Rabigam. This was a case sent to me by Prof. Bloomberg. So you can see this is a jackal, all right? I think this was somewhere in the Eastern Cape. You can see this is a guide who works a lot with the animals and essentially had a nice little munch to his leg there. Very small wound. He wasn't too worried about it. The photo was sent through. You know, there's with the Leatherman. You can see it's very, very, very tiny little puncture wounds. High risk, low risk. High risk, high risk, high risk, category 3, wound exposure, patient gets wound care, vaccination, and immunoglobulin. An Art Wolf bite, have a look at that. No, man, it's just a little scratch. Hey, barely even broke the skin. Sure, that's fine. High risk, low risk. Okay, we all agree it's still extremely high risk. All right, so it's a wild animal, especially a canine sort of species. Break in the skin of any kind, that would be a patient where you would actually give that full, either 20 units per kilogram of the Rabigam or 40 units per kilogram of the Gqeberha, and you're gonna inject it into that wound. You're just going to try and get as much of it in and around that teeny tiny wound as possible. Now, a bit of an interesting one. The NICD recommend that you treat any bat exposure as a category 3 bite. So if somebody says a bat landed on their head, because they can make such teeny tiny little bites and they can make such teeny tiny little scratches that you may not even be aware of them, they actually recommend that any bat exposure gets treated as a category 3. And so if you do have any patient who's had a bat exposure, they will then get all of the above. So the immunoglobulin you'll then put wherever the bat sat, wherever those teeny tiny scratches might be, and they'll get their vaccination and wound washing there as well. Mongoose, again, appeared on our list earlier. Wild animal, high risk, definitely all of the post-exposure prophylaxis. Here's an example of how subtle category 3 bites can be. Remember the bat on the head, could even be just a little bit of a cat. Maybe this little kiddo was out playing with a dog. You know, you never know. A category 3 exposure can be as small as those teeny tiny little scratches, and that you would still treat as a high risk. And then finally, a very, very, very tricky one and a bit of a controversial one. What do you do if there's been a mucous membrane exposure? So in other words, potentially rabid animal that has actually licked a mucous membrane. So in other words, you don't actually have a wound that you can actually give the rabies immunoglobulin into. The current recommendation, it is a bit controversial, but is actually then not to give the rabies immunoglobulin. Previously, we would have recommended give it intramuscularly, but because we know the rig doesn't actually work if it's given IM, the current recommendation is to wash out the mucous membranes as well as possible, and then give the full course of vaccination without actually giving the rig in this case. So this is the only category 3 exposure where you would actually not give the rabies immunoglobulin. Some people do talk about, and I think I would probably do it if it was my patient, they do actually talk about actually taking the rabies immunoglobulin and actually using it to wash out the mucous membrane and actually washing out the eye with it. Again, not very evidence-based, but we are desperate. We know that this is something that we definitely want to prevent. So I probably would do that, but it's not currently in the guidelines, and there's currently no evidence behind that. So in summary, rabies is just about 100% fatal and 100% preventable, provided that the patients get the full course of the vaccine and the rig. You need to think about the wound care, the vaccination, and the rig in every single case, all right, if they are high risk, and make sure that you know your local guidelines and that you know where you can find PEP. I'm going to stop there.
Thank you very, very much. That was, you're always very practical, and yeah, very much helps to, I think everybody's very clear now about exactly what to do, which is very, very brilliant. I think I just also want to add is to remember your district vets. Very helpful to work with the vet teams when you're having a local rabies epidemic. My kid's one of the ones on the vet side. They go and walk the townships and immunize dogs. And then I realized the other day we had a talk from Lucille at this SAFP conference. And I suddenly realized I haven't given my child pre-exposure prophylaxis, and they're walking the towns giving. So yes, yeah. So it's sometimes to remember that these things actually happen all the time. There's a couple of small semi-questions, comments. The one was around what you just cover with broad spectrum antibiotics for a short period. So if you've got a bite of a dog and it's not looking septic at the moment, what would be your first choice of antibiotics, and for how many days would you prescribe it? Do you have what does the ML say? I'm not even.
Oh, yeah. So again, you've got to decide which bites are sort of high risk and low risk. And again, this is not for rabies prevention at all. This is really just to prevent hand sepsis and things like that. And again, you've got to have a look at your patient. But if your patient is potentially immunocompromised, if it's a hand bite, if it's a face bite, if it's something that can potentially get septic, I do err on the side of giving a broad spectrum antibiotic, something that's going to cover anaerobes. All right. So I would be reaching for augmentin, not amoxil, for example. Just and it would only be for a short period of time, and then you obviously just let your patient know your risks and when to come back. Again, it's not necessary. You've got to have a look at your local guidelines and the EML. There are going to be sources that are going to say don't give antibiotics routinely. I mean, as I say, I would not give antibiotics for my safe dog bites and my dog bite on my hand. But if you are worried and you have patients who may not have you know, may potentially have other reasons to be immunocompromised. They're diabetic, they're on steroids, you know, you or HIV, you may want to think about giving that short course of antibiotics.
Great, thank you. And then there's a question, is the vaccine ineffective? Should the patient skip one of the vaccines or doesn't get it precisely on those particular days? So anal should we be about the...
So it's such a great question. What do you do if the patient has missed one of the days? So again, it's one of these things where we're never going to go and do a randomized control trial, right? We're never going to go, well, let's give you the vaccine on these days and you skip a few days and let's kind of see what happens. To the best of my knowledge, if you have missed a day of the vaccine, give it again as soon as that patient then represents. So make sure that we counsel our patients and say, if you do miss, just for example, in the setting that I work in, sometimes the clinics are closed on a Saturday and a Sunday. So you know, then we say, well, come back here again. But if they do miss the day and they come back again the next day or the day later, then what they then recommend is then start again from that date, but then do continue, or that they make sure they get all four.
Thank you. And then there's a last question here, considering the 10 minutes wash. So if someone was bitten superficially earlier in the day, or you might also have somebody who's been bitten like a day or two ago, will you, for example, scrub enough to remove the clots and get the wound to actively bleed again? Or do you just watch over? You know, how long is that 10-minute wash still relevant for an old bite?
I would probably wash enough to get rid of those clots, get rid of all the dirt there, get it to actively bleed. I would treat it the same as you would treat kind of almost like a contaminated wound, yeah. So yeah, and that's the reality. Patients very seldom are going to present straight away. They might present a day or two later. But yeah, the idea is that you really give that wound a really good wash. And again, if you have to give the patient procedural sedation to do so, especially if it's a child, then do that.
Great. Thank you very, very much. For everybody, just please notice we've put a poll up. It's partly what we need to be able to prove that people have attended our course. And we do like to look at the evaluation form. So please fill those in before you go. But I just would like to say really thank you. And again, this is now a great resource. So all my interns are going to be getting sent this every time they arrive in my department, for example. And so it's really great that you've done the effort to make such a great presentation, and that you've spent this evening here with us for the last hour. Thank you very, very much. Appreciate it. And we will be calling on you again for another topic next year.
Oh, great. Thank you so much, everyone. Thanks so much, Madeleine, for having me. And thanks everyone for being here, and continue the hard work. I know that many of you are working in really, really tough places. I think a lot of us are working under a lot of strain, and hang in there, guys. What you do matters. Take care of yourselves, continue taking care of your patients, and just all the best to all of you.
Right. Thanks very much, Sean. Have a lovely evening, guys. And we'll see you
Take
next
care.
month. Sure. Good night.
Bye.